Assalamu alaikum. Welcome everyone on board. Today we will be trying to cover some topics of ICU. Before we start, um, just a second. What do you think that there are the challenges while you are working in ICU? What are the general things we should be focusing at? Why the patient was coming to ICU? Indications for which patient is coming to ICU. Okay, how to evaluate daily regarding the progress, or like it will also be the initial impression of the patient, and then how you follow the progress. Okay, then like for example, if there will be two categories of patient, like the one will be for any surgical, you can just broadly divide the patient into say, and some will be medical, okay, in origin. Then some patients will be due to some unwanted, sorry, unexpected clinical situation which occur during surgery, for example, like any MH occurs, sucks apnea occurs. So these patients will be coming for ICU care. Okay. So what else? Any systemic problem can be decompensated. Like for example, if you are thinking about obstetric patient, so obstetric patient with cardiomyopathy can end in ICU.
उसको निकालो तो निकलेगी हाथ धोई जा रही है
Okay, so this one preeclamptic patient with PIH. Okay, similarly, like local anesthesia, systemic toxicity if following epidural. Okay, so this is just I'm giving you example. So in every patient, like for example, if you are thinking about orthopedic, patient may have fat embolism, pulmonary embolism, okay, bone cement syndrome. Um, so like first thing will be that why the patient was shifted to ICU. Okay, this is the basic first thing you will be thinking. Then you will be looking at the systemic evaluation. So if you just start from CNS, then CVS, then respiration, then endocrine, then this one metabolic, okay, renal, liver, and the general care like lines, okay, for lines and tubes, okay, then like bed sores, okay. So we will just try to just so if you want to evaluate this, for example, CNS, so what thing you should be keeping in the mind? What maybe the patient may be having low GCS, or patient will have delirium, okay, or patient will be low GCS maybe in the form of because of uremia, okay, encephalopathy of origin of liver or kidney, okay, or patients have some basic neurological problem like stroke or hemorrhage, okay. Hemorrhage may be following a trauma or maybe following a medical condition, okay. So like subarachnoid hemorrhage, or any other hemorrhage. So what else will be some neurological deficit? Okay, so neurological deficit may be in like the basic cranial nerves or motor system or sensory system or autonomic system. Okay, so like and there will be a number of conditions in ICU in which you will be focusing on the autonomic system. For example, we discussed 2 days ago about GB syndrome, about tetanus. Okay, so this is this example of this system. Motor system, for example, there is development of ICU acquired muscle weakness. Okay, so in that there is involvement of actually all the systems, but usually this will be one example of one thing. Or in so like in each of the things you will be focusing on presence of any cranial nerve deficit or motor deficit or sensory deficit or autonomic deficit. Okay, so autonomic will be in the form of hemodynamics. Okay, and motor will be in the form of failure to be weaned off. Okay, so this will be like motor. You don't want the patient to run, but if you have a patient with any motor problem, the patient will not be able to be weaned off ventilator. Okay, so okay. Similarly, with reference to GCS, how can you evaluate the patient on ventilator? Okay, so either the patient will have endotracheal tube or the patient will have tracheostomy tube, for example. So then you cannot evaluate the verbal part. Okay, so you have to uh, like have some alternative way, or you can have this AVPU. Okay, awake, verbal, pain, or unconscious. So this is one of the way to see the conscious level. There are some certain other things which you follow in this patient, maybe in the form of delirium. Can anyone mention the evaluation for delirium? What scores are being used? It is better if you people interact. Yes, Anila.
Sir, delirium, can I speak,
Yes,
sir?
Jamil. Yes,
I
yes.
am actually calling, but I will participate, inshallah. Actually, there is two tools to assess the patient in ICU for a delirium. There is ICU delirium screening checklist, and the second is CAM ICU. ICU delirium screening checklist actually showing
Be
eight
a little
only.
loud, Jamil. Fida.
Yeah, yeah. There is two checklist, two tools in the ICU to assess the delirium in ICU. First is ICU delirium screening checklist. Most of the time, it's doing by the nurses every 8 hourly, and there are some 8 parameters. If we assess that patient, then we assess more than 2 scores. Then we assume that is going to the to develop the delirium. And for physician is CAM ICU, confusion, agitations. What is CAM?
Monitoring.
Yes, the confusion assessment management method in ICU for the delirium. Most of the time is doing 24 hours by the physician. And the first, if there we can assess by the 4 things. If pneumonia is FIDA. FIDA means fluctuation.
Cam,
Uh,
just a second. Jamil, try to speak a little louder so that everyone is benefited. CAM ICU is confusion assessment method. Okay. And IDC, you were saying the
yes,
intensive care delirium screening checklist. Okay.
yes. ICU delirium screening checklist. I saw that as it's most of the time done by the nurses staff, and they just evaluate the patients may be develop after some time the delirium, and by the physician if there is means in checklist nursing checklist there is 8 more parameters. One of
So
them
just
is
a second. Jamil, you forget to mention about, I was expecting Richmond, agitation, sedation scoring, and
scoring.
Ramsey,
Yes,
Ramsey scale.
Ramsey actually, sir, Ramsey is different. It's doing in awake patient, or they we are talking about the level of sedation. But RAS, Richmond agitation score, sedation score, actually it's in intubated patient that admitted in the ICU. There are different levels. It started from 0 to plus and from 0 to minus. It depends upon the sedation level of the patient. 0 should be patient alert and calm, and in -1 patient is slightly drowsy, but he's responding to the verbal response and he's open the eyes more than 10 seconds. If we talk about the -2, it's patient more moderated sedated. And if we, sorry, if you want, I just in that detail. Otherwise, there is -1, 2, 3, and 4.
Yes, Jamil,
4
just
is
a second. Actually,
yeah.
I want, because I have to cover a lot of things. So I'm just giving a baseline idea about, because
Yeah.
we started from the how to evaluate the neurological system. Okay, so
Yes, sir.
just came this delirium. So I just wanted to have an idea
Yeah.
about. So actually,
Okay, sir.
just a second, please. You see, if you can mute your mics, please. This is very distracting for everyone. Okay, so FIDA, actually I couldn't recall. I wrote a little bit different. Fluctuating mental status, inattentive behavior, then this conscious level, okay, in which there is disorganized thinking, and so that's how you will be evaluating the patient with the
Yes. A
possible
is altered sensorium. Fida is
altered
fluctuation
sensation.
pattern, sir.
Yes, FIDA. This was actually, if you remember, we made this mnemonic.
Yes, Fida is the fluctuating pattern. Means patient may be sometime
Inattentive.
hypoactive,
This
hyperactive.
is inattentive. Okay.
Yes.
And
Inattentive. He
disorganized.
is
This,
disorganized thinking,
yes.
and A for altered sensorium.
Okay. So this is like, just like, so one thing is delirium. Okay. Other is for delirium, we talked about this thing, but generally the tools for assessment of the neurological system or conscious level is, one is GCS, one is AVPU, one is Ramsey scale. Okay. And this SCAM ICU, Richmond agitation sedation scale. Okay. So this is just to evaluate the N for motor and sensory and autonomic. So this is how to evaluate the patient regarding the central nervous system of this was my aim to just tell you, because if you will have these things in your mind, it will be easier for you to even manage the patient in ICU. And if they're, like we are talking about the exam scenarios, should have these things in your mind. Okay. So similarly, because if any problem in conscious level or motor system or sensory system, you will be expecting in certain conditions. Okay. Okay. So okay. So like again, I will just finish this point and then I will go to the next system. So the things which you should be in your mind will be like evaluation of ICU acquired weakness, any neurological problem, which may be of any origin, and any other neuromuscular problem. Okay. So this is how you will be evaluating. So now if you go to cardiovascular system, okay. So in cardiovascular system, how will you evaluate? Like the vital signs, blood pressure, heart rate, okay. And then you may have arterial blood pressure monitoring or cardiac output monitoring, okay. Or you have to assess the volume status, okay. Actually, this question was asked to me in my table viva regarding ICU. So how will you evaluate the cardiovascular system in an ICU patient? So actually that was, I don't know how I answered, but it was only purely on the basis of the concept. So volume status, you can see the generalized skin, turgor, mucous membranes, okay, and circulatory status, like for example cold versus warm, okay. And the baseline will be that in any ICU patient, that all these things will be either spontaneously or with the help of some inotropes or vasopressors, okay. So this will be the bottom line, that if for example patient is maintaining blood pressure of, for example, whatever, so you will say that either it is spontaneously or with the help of some inotropes or vasopressors, okay. Or any invasive device like this one, intra-aortic balloon pump or ventricular assist device, or like specific cases, okay. So then there will be something about ECG and echo, okay. So in echo specifically, of course, transthoracic echo, but here will be the use of T and ultrasound of vena cava will tell you about the status of the volume status, and whether, because if there is, we discuss in detail about shock. So if some patient is in shock, whether that is responding to fluid or inotrope or vasopressor, okay. So you will be deciding about on the basis of a number of factors. One of them will be ultrasound of vena cava to see the fluid responsiveness through the TTE, transthoracic echo, with the this one contractility, okay. Because now in recent advancements, ICU management is not blindly. Another thing I am will be like CVP or pulmonary artery catheter, okay. But usually the findings which used to be gathered from pulmonary artery catheter or CVP, for example, now they can also more reliably through A-line or cardiac output monitors, okay. And actually your purpose is to see the end result is that whether there is some ischemia going on, okay, whether there is some overloaded condition, whether SVR, how is SVR, okay, how is cardiac output. So like your aims, because that's how you will be doing or changing your management, okay. So evaluation of cardiovascular system in ICU will be according to which I have told, of course, the oxygen saturation, and then blood pressure, heart rate, and the things which I have told you through ECG, echo. So this I'm just revising. So cardiovascular system, you will be evaluating like that. Of course, there will be some correlation with other systems, but that's how you will be focusing. So we will keep on repeating. Then what are the common decompensatory thing related to cardiovascular system? It may, of course, it may be any, because the patient in ICU is under stress. So in stress, there will be ischemia, okay? Or if the patient is having multi-organ failure, Even in that patient, there will be like a cardiac depression or anything like that. So you should have these things in your focus, and the result of failure of heart will be evident in the lungs. Okay. So now we will correlate it with the respiratory system. So respiratory system will be, of course, if the patient is either the patient is on spontaneous ventilation or patient is under any help. Okay. Any help means only oxygen therapy via nasal cannula or face mask, different varieties of face mask. This will be telling you a lot of giving you information that whether it's simple face mask, okay, or it is with non-rebreather, with non-rebreathing valve, this mask. Okay. Or next step will be Venturi mask. What is, can anyone tell what is Venturi mask? Dr. Anila, would you like to say what is Venturi mask? Zishan?
Yes. So a venturi mask is a mask which in which we can adjust the FiO2, the
Sorry?
fractional inspired oxygen. So venturi mask is a mask in which we can adjust the FiO2. It's a
Mm,
type of a face mask basically.
actually, it's a fixed performance device. Okay.
Right.
And there are the color coding because it will be like it's a fixed performance device in which you can accurately monitor the FiO2 you are giving to the patient. Okay.
Yes.
So
It works on the principle of Bernoulli
Then-
principle, and it entraps, I think, from its opening.
yes. Okay. Venturi principle.
And on eventually, it was in my OSCE, I think, color coding, how much different color coding were eventually devices
Yes.
were there, and I was asked all these questions.
Yes, actually, yes, we are actually peeping through a number of topics. The topic which they can ask you for this is oxygen therapy. Okay. And also they can ask you about what are different oxygen delivery devices. This is the delivery system. Okay. So just to finish seal of this topic is that in certain condition when we are giving hyperbaric oxygen therapy, they have oxygen hood or oxygen tents. You can read about it in detail, but I'm just giving you a concept that nasal cannula, different type of face mask, Venturi mask, then this and then next step to this will be CPAP, BiPAP. Not CPAP will usually, it's BiPAP actually. Okay. So BiPAP is with the IPAP.
Excuse me.
Yes.
Sorry, not related to this topic. For nasal cannula, I was asked about complications or side effects. So dryness of the skin, it was basically it was asked.
Yes, dryness. Okay. And it cannot deliver more than maximum. What is the maximum FiO2
No,
delivered
there
through?
is two actually.
40%.
He is talking about high flow nasal cannula and there is simple nasal cannula. In simple nasal cannula, there is maximum 3 to 4 liter, but high flow nasal cannula, yes, there is might be the flow up to 60 liter. This is the other things.
High flow nasal cannula is a detailed topic we will discuss later on. It has humidified humidification system, and this got more attention during COVID era. Okay. But you're right. He is talking about simple nasal cannula, Jamil.
Okay, sir. Okay.
So BiPAP, and similarly, there is another mode of ventilation other than the normal mechanical ventilation, that is high frequency, either high frequency jet ventilation or high frequency oscillatory ventilation. Okay. High frequency positive pressure ventilation, all these types. So then will be mechanical ventilation. I will just try to give you a broad view. Okay. So before that, we will be evaluating the respiratory system on the basis of whether the patient is dependent on anything or not, and then any signs of respiratory distress. Okay, that we have discussed in detail before, but usually it is either upper airway obstruction or lower respiratory tract obstruction. Okay, upper airway, there will be signs of any upper airway obstruction or in lower airway obstruction in the form of any like wheezing or this rhonchi and this one crepitations. Okay, so you will first thing will be how you will be assessing any sign of respiratory distress in the form of rate, pattern, use of accessory muscles. Okay, because on those basis you will decide whether this patient needs any further intervention or no, or if you have, and in certain condition you will be thinking about peak expiratory flow rate. Okay, or any findings of spirometry, specifically peak expiratory flow rate or any other finding related to spirometry. And then this will be one thing. Then there will be maybe pathology of the disease, maybe directing you that you will be doing anticipated management of airway. Like for example, if you have patient with burn, you will be anticipating. If you have patient with GB syndrome, you will be anticipating. If you have a patient with the anaphylaxis with angioedema possible, you will be anticipating. Or if you have any patient with stridor, you will be anticipating. I'm just giving you an overview that how you will be targeting. In addition to the pathology and the general impression of the patient, the next thing which you will be focusing we have is the ABGs. Okay, so you will be looking at the pH, you will be looking at the PO2. Okay, this is more important, and then you will be looking at PCO2 and bicarb. Okay, so on these basis you will be, but remember one thing, you don't have to treat ABGs, you have to correlate a whole picture. Okay, if the patient has problem with the conscious level, blood pressure is falling down, now the patient is also desaturating, CO2 is, then you will be making a decision, not only on the one basis that pH is low, I have to intubate, or PCO2 is high, I have to intubate, and you will be going gradual. So your management will be according to that. In certain condition, you will have chest X-ray. Okay, chest X-ray, and now recently it is replaced by ultrasound. Ultrasound chest X-ray, you can have acute conditions like pulmonary edema or pleural effusion. Okay, things like that, or pneumothorax. Remember one thing, we are focusing with the basis of ICU. So our thinking is related to ICU. And another thing I'm telling you, the things which I'm telling you, it is not related to one topic. It is not related to it is just related to how you should be approaching, or how your brain should be working if you are discussing any topic related to ICU. Okay, so in ultrasound you can have according to the B lines, you can find that this patient, because X-ray is more invasive. X-ray may be needing more manpower, bringing the portable ultrasound, also this one X-ray machine. So ultrasound can give you that same information very quickly. There is some even it can diagnose pneumothorax, it can diagnose pulmonary edema. Okay, it can diagnose pneumothorax, as I told you, pulmonary edema, and even confirmation of the position of the lines. For example, if you intubated a patient and you can see the endotracheal tube position, you can confirm the NG tube position. Okay, so ultrasound can give you a lot of information. Okay, so I think this is how you will be evaluating the patient related to respiratory system and CVS. These three systems we have covered. Now what else? Now we will be just trying to look into the other things. What one of the most important thing is intake, output. So intake may be oral or through NG tube, or gastrostomy tube, any like this will be and either it will be IV. Okay, so these two routes and output will be in the form of course, stool, urine, and other sources of like any this one drains. Okay, and insensible loss, like for example,
And YouTube
if,
also, sir.
sorry, NG tube I've told, NG tube. Yes, Jamil, what did you say?
Yes, I told about the NG, but might be, I missed that.
Yes, drains, any drains.
Yes, anyway.
Okay, so you will be evaluating on these basis. So IV, like you should be knowing whether the patient is in positive balance or patient is in negative balance or in the even balance. You should be knowing it, and especially because this will be a big factor when you will be planning for weaning. If the patient is positive, it is one of the factor for delayed recovery from the ventilator. Okay, so this is very important. And similarly, in IV, the baseline will be nutrition. So you will be looking at the nutritional requirement. First of all, you will be assessing the nutritional status. Then you will be calculating the calorie requirement. Then you will be thinking any precaution needed. Okay, and then you will be deciding enteral versus parenteral. Okay, and then the possible complications. This will be related to the lines or related to the formulary. If you want to assess the topic, target the topic of nutrition, you should be doing like that. Assessment, there will be some tools to assess the nutritional status. Then you will be calculating by some crude methods like 20 to 30 kilocalorie per kg per day. This is a crude method, or in the on the form of calorimetric method. Exactly, this is one thing. Then you have to calculate how much fat you need to give, how much carbohydrate you need to give, what about proteins. Okay, in the certain condition you need to reduce proteins, or certain condition you need to reduce carbohydrate, things like that. And then you will be calculating the total fluid you can give by either route, and then you will be calculating the percentages of the solutions. Okay, so your basic purpose is to avoid protein catabolism. Okay, like nitrogen balance. And if you have any problem with the kidneys, you will be avoiding the proteins. And if you have any problem related to respiratory tract system, then you will be decreasing the carbohydrates. In addition to that, those things, you will be looking at the this one nutrients, other nutrients, vitamins. Okay, I'm just giving you, because we cannot discuss all these topics in one setting, but I'm giving you that nutrition you have to assess, calculate, precautions, lines complication, how to start. Some complication will be only at immediate starting or stopping. Okay, one of the thing they can ask you is about refeeding syndrome. Okay, so so intake, output, nutrition. Then important thing, which is one of the factor for delayed recovery from discharge from ICU, is serum electrolytes. So sodium, potassium, magnesium, calcium, and phosphate. These five are very, very important. Sodium is related to CNS, and it is related to the conscious level mode. Potassium and calcium, and actually magnesium phosphate as well. But usually potassium and calcium are related to heart. Okay, and magnesium and phosphate, you can label it as skeletal, like muscles. But actually they all can affect heart as well. Okay. So what will be the inference that, for example, if you have a patient with hypernatremia, you when you are giving the fluids, you have to think about what fluid you should be choosing. Like if you give D5 NS, for example, 5% D5 NS, then, for example, if the patient is this one hyperglycemic, then it will be a problem. Okay, so you have to adjust the insulin accordingly. If, for example, if you have a patient with hypernatremia and now you have to treat, for example, this patient need bicarb and the sodium is already 150. This will be a big problem if you give soda bicarb. Okay. So in that condition, I don't know much about it. I have not used it, but there is a solution which is called as THAM solution. Okay. And there is a big abbreviation for it. It is to treat acidosis. Okay. But it does not cause volume overload and sodium overload. Okay. This is just one example for it. Okay. So again, just related to that thing, just continuation, you have to think about the magnesium levels, calcium levels, ionized calcium level, phosphate. Phosphate is one of the big factor because the whole of the metabolism is through this formation of ATP, and there is hypophosphatemia. There is big problem in related to weaning. Okay. So phosphate levels are very important in this regard. So you have to maintain sodium, potassium, magnesium, calcium, phosphate. Of course, one thing I have to tell is the glycemic control. Okay. We have discussed before when we discussed diabetes mellitus that you have to maintain the liberal glycemic control. Okay. So you have to maintain around 120 to 150 milligram per DL. Okay. So
Even sir 180. Now is recommended between 120 and 180.
Jamil, remember one thing, don't try to be this is the most what you say the more majority of people will be knowing this. If you have read it somewhere 180, remember one thing, not everyone will be knowing it. So don't try to make yourself confused by these small things. The basic principle is that the tight glycemic control is a problem. Okay, because there are chances of hypoglycemia.
Yes, sir.
And the basic principle, why 180? Now you tell.
Just
Why
to
180?
avoid hypoglycemia. Yeah, I agree. Because
No.
hyper
What is the significance of this number 180?
No, actually, it's now I am talking about the guidelines, about the strict glycemic control and the liberal glycemic control. In liberal, there is a further mention between in mole 6.5 up to 10 millimole. And if in milligram per decile, they told 120 to 180.
Okay, anyways, the 180 is because of renal threshold. So you have to keep in any way less than 180. Okay. So this is 180 number is not favorite or other than this renal threshold. Okay. So this is so related, just to recap, we discuss about CVS, respiration, and this CNS, intake output. Okay. And serum electrolytes, similarly fluid balance, nutrition. Okay. Then very important one of next will be related to just a second, urine output. You have to maintain more than 1 ml per kg per hour. Okay. And if there is any, the resultant will be in the form of like you need to go for fluid restriction, or if, for example, if the cause is pre-renal, you will be giving fluid challenge. Okay. You will be looking at any risk factors which may be a factor for AKI. Okay. So urinary system you will be, and the last resort will be CRRT or dialysis. Okay. Then another thing is about lines. So 9 lines may be CVP. What care is needed for CVP? There is CVP bundle. Can anyone tell about it? What things you need to consider when you are having a CVP? Which site is better?
Sir, the subclavian is the
Least.
least
Right
infected site.
internal jugular. Right internal jugular is better.
No. Who said right internal jugular?
Sorry.
No, Osman. For related to infection, it's subclavian.
Okay.
And another thing is that internal jugular, there it is like if the patient is awake, for example, then even then there are problems related to mobility. Like ambulation will be problem with line in the neck. Even for long term, subclavian is better as compared to internal jugular. Okay. Another thing is that what is replacement for CVP is PICC line. Okay. So in certain even this parenteral nutrition, okay, is the terminology which we use is peripheral parenteral nutrition, okay, through PICC line. Okay. And what is related to sterilization is chlorhexidine is better than iodine. Okay. What else? How
Hand hygiene.
after? Sorry.
First of all, hand hygiene.
Hand
Whenever
hygiene.
handling the CVP, hand hygiene should be performed before inserting and before handling. Then the care of the site.
There is
sterilization and
chlorhexidine covered dressing. Okay.
Sir.
There is a special dressing for CVP, and the nursing care, nurse to bed nursing. Okay. And if there is any signs of inflammation or infection, okay, then you need to send the culture. If until it is strongly needed, you should not keep it. So these are the things. There may be some others as well, but I'm just trying to give an idea about the lines. Similarly, arterial line.
Daily assessment.
Sorry,
Sir, daily assessment.
I cannot hear you.
Sir, I said daily assessment of the line, review of the line.
Yes, assessment of the line. Yes, you're right. Okay. Not only this, these things will be general for even Foley's or any drains the patient have. Okay. Because the other lines which may be there is CVP, pulmonary artery catheter, dialysis catheter, PICC line. Okay. So the general principles are the same. Okay. And yes, now because we are taking a lot of time, I have to cover I have to seal it back. So now some other things related to like risk of thromboembolism, thromboprophylaxis. Okay. So thromboprophylaxis as well as bed sores. Okay. So for that, there are certain ways that there are for bed sores, for example, there is a special mattresses, air mattresses. Okay. Then not only related to bed sores, also related to the ventilatory management. Okay. Ventilatory management, there's also this positional changes. Okay. Like in the form of intermittent prone positioning. Okay. And another, if the bed sores are developing, immediate involvement of the respective team and to handle them. That the bed sores is a big source of problems related to ICU patients. Okay. So care of bed sore, mattress, this positional change, intermittent, and then similarly there will be some like compression devices. Okay. And this one, special dresses, thrombo elastic dressings. Okay. Then what will be the other, in addition to pharmacological prophylaxis, you will be avoiding certain factors. Okay, like because in these patients, one of the factor is dehydration. So patient should not be volume depleted, and usually this is not there in majority of ICU patients. Usually they are overloaded, but this is one of the factors which you should be thinking. And again, you will be making a scoring system to evaluate the risk, and then either one thing or more than one thing. So actually, there is one formula. Now we have covered a number of fun, Pagi, or what is that? Feeding, ulcer prophylaxis. No, it's not fun, Pagi. I think it's something else. Can anyone tell? Journal ICU care.
I think flat chugs and flat chugs is one formula.
Osman, unfortunately, I'm not able to listen to you, or you have some problem in your mic.
Yes, sir. Sir, it was flat chugs or flat hugs in bed. There are two mnemonics.
Fast hug, sorry, not fun, Pagi. This is something else. You see?
Yes, sir. Fast hugs in bed. Fast hugs in bed
Feeding.
or flat chugs.
Feeding.
Yes, sir.
Aspiration.
Aspiration. Yes. Sedation.
Sedation.
Sedation breaks.
Sedation breaks.
Thromboprophylaxis.
Thromboprophylaxis.
Yes. Hydration.
Hydration.
Ulcer prophylaxis.
Yes, ulcer.
And
Prophylaxis.
glycemic.
Glycemic control.
Yes, sir. Yes, sir. And in beds also, fast hugs in bed.
In bed. What is with N beds?
Sir, I for indwelling catheters and for nutrition.
N for nutrition.
And
This N is here. Feeding. Feeding is there.
yes, sir. Nasogastric, I think NG, it was like this.
Indwelling
Neuromuscular
catheter.
blockers. Yes, sir. Neuromuscular
Yes,
blockers.
neuromuscular.
Yes. And sir, D for delirium, E for enteral feeding. It was like this. I'm forgetting all.
Okay, anyways, we have just because if you know this, the rest of the things actually becomes very, very simple, believe me. Because if we just go in another way, what are the usual medications the patients are taking in ICU? Either, for example, it is some inotropes or vasopressors for hemodynamic support. This is one of them. One thing is antibiotics. Okay, antibiotics should be guided through culture, and culture will be either blood cultures, sputum cultures, okay, urine cultures, because these are the possible sources. Endotracheal tube, sputum also specifically through endotracheal tube or any lines. Okay, so this is one thing. Then they are taking any, for example, steroids. What will be the indication of steroids in ICU? Yes, please.
So if the patient is already on steroids for the long time.
Steroid replacement. Steroid replacement. Chronic steroid use for any condition. That what else?
Sepsis.
Yes. What is role of steroids in sepsis? What is role in ARDS? What is role in septic shock?
There's not much proven benefit, but it is used as an adjunctive therapy when other therapies have failed.
Sir,
Remember
in ARDS, early, if we use in a small amount in early phases, then it is somehow
early phases?
beneficial.
No. ARDS, you see, try to say don't follow the COVID life only. Okay. In COVID, everyone, even the street man was using the word dexamethasone and everything. But what is written in the articles and previous sources, ARDS, the fibroproliferative phase of ARDS. Septic shock, Zishan, please don't complicate. Zishan, you were saying no proven role. You are not doing a research work, by the way. In the exam, you have to tell the things which our examiner is asking you as a resident. Okay. So please try not to go in with the words which can catch you. Actually, it is for fluid resistant and vasopressor resistant. If nothing is working, then you have to replace, you have to give steroids, hydrocortisone.
Fluid resistant shock and vasopressor resistant shock.
Yes, if you see the guidelines, okay, if you have given vasopressor in septic shock, okay, then you have given fluid in addition to that, fluid, vasopressor, then what else?
Yes, sir.
Inotropes. And then if nothing is responding, then you have to give steroids. Okay. This is written in the guidelines, hydrocortisone. Okay.
Yes, sir, I remember.
So otherwise that in ICU, you can use steroids for airway obstruction. Okay. If there is some, because you are using some antibiotics and everything, so there may be some anaphylaxis or any reaction. So they have asked these questions to various people, what are different use of steroids in perioperative period. Okay. So some of them are there in this way, and also some steroids for if the patient is with COPD exacerbation. Okay. So this is for steroids. So what else? So ulcer prophylaxis with, how we do ulcer prophylaxis?
Sir, by
With
antacid,
PPIs.
PPIs versus H2 receptor antagonist. Okay.
Yes, sir. And early enteral feeding also.
and
Yes.
antacids.
Enteral feeding. Okay. Especially if you are giving steroids, for example, it has a special relation, or patient is taking NSAIDs. If you are giving NSAIDs for certain reasons, these patients will be at high risk. And another, it is also as a prophylaxis for VAP. Okay. We will go into, because maybe when you will be listening, you will be thinking that what are we doing, what topic we are studying. But believe me, if you understand what I have told you in previous 1 hour, all ICU is piece of cake. Nothing is remain. Now if we will target any specific topic, then you will come to know. Okay.
Sir, one question.
Hmm.
If we give H2 blockers or PPIs, are we increasing the risk of VAP or decreasing?
Risk is increased with PPIs and H2 receptor blockers.
Yes, so I think VAP prophylaxis should not be in the list.
Just a second.
So the concept is that if the acidic content is reduced, more alkaline environment
Yes.
is present, the bacteria proliferate more.
Yes,
And,
so I
they can
think
cause
VAP
VAP.
prophylaxis should not be in the list. It increases the risk of VAP, the use of PPIs and H2 blockers.
Just a second.
For prophylaxis of VAP, we actually have to avoid PPIs in those who have low risk of developing
Yes.
stressor.
Just a second. Actually, we will be going into details of individual topic VAP, and so there are a number of things we will reconfirm it. Okay, because if I'm
was
not
It's written
wrong,
there, a little
you
above,
are
sir.
sorry.
On the above paper, it was written. On the above page, it was written under prevention.
Okay. Because that for that thing,
Under prevention, in the second paragraph, it's
actually
written.
remember one thing. There is it's a complex use. What they have written: stress ulcer prophylaxis raises gastric pH, which is detrimental to innate immunological protection provided by gastric acid. Okay, stopping stress ulcer prophylaxis in low risk patients, those patients absorbing feed without a history of gastrointestinal bleed is recommended. Okay, so you can there are chances, but in one way it is increasing the chances, in the other way it is decreasing the chances. Just tell me one thing. Now I will prove it to you. Tell me one thing. If there is micro aspiration, what is the factor for more problematic pneumonia? Is it with acidic or basic?
Those are two separate things. For VAP develops due to infection, which will be due to bacteria. The bacteria will proliferate more if there is less acidic environment. You're talking about aspiration risk. Aspiration risk, of course, the aspiration pneumonitis risk will be increased if acidic content is going into the lungs.
No, you are absolutely right. I'm just telling you, I'm not denying your word, Zishan, but you are only holding one side. I'm telling you that there is no consensus on it. Some people
Yes, sir.
say that it is related to they compare it with the H2 receptor antagonist versus proton pump inhibitors. So they say H2 receptor antagonist is better. Okay, so there is a complex. So one thing is favoring of use, one thing is in favoring of not use, because you see, aspiration is one of the leading cause for VAP. Okay, micro aspiration. Why they are doing this and supraglottic suctioning? Why they are doing it?
Yes, sir.
Supraglottic suctioning is for it. Okay, because the concept is that if something there is micro aspiration, especially after the feeding, especially with intermittent feeding, because feeding, there are two ways to do the feeding. One is intermittent and one is constant via infusion pump. So if you are feeding the patient with continuous, there are less chances of aspiration. So there's less chances of VAP, because theoretically there will be less chances of microaspiration. Okay, so your point of view is correct, but I'm just correcting your answer in a way that you say that there is no consensus guideline whether to use or not to use. You have to individualize the management, because if you are using antacids or PPIs, in one way it is helping out, in the other way it is not helping out, rather it is increasing the incidence. Okay, so that's what I wanted to tell you only. Okay, so in addition, for VAP prophylaxis there are so many things. Positional, head side up. Okay, then what else? Sedation breaks. What else? 30-degree, this head up. Okay, so we will consider it. What other medications the patient may be taking, ICU patient, which you are giving? This antibiotics, inotropes, vasopressors, this one, ulcer prophylaxis, steroids, insulin. What else? What I was writing here: selective gastrointestinal tract decontamination. What is the use of it? Then oral hygiene. Okay, oral hygiene through chlorhexidine. Okay, anything I'm missing? Any other common medication which ICU patients are taking? Yes, Zishan.
So sorry, I got distracted.
There are
So
sedatives.
all the medications,
Sedative?
yes,
Yes, very good.
sedatives, relaxants.
Sedatives. Okay, so let's discuss about sedation and analgesia. Okay. So we have discussed before while evaluating the patient with the neurological system and sedation. So first of all, of course, you will be evaluating the level of sedation needed and the status of the patient according to the liver problem, renal problem, cardiovascular status. But what are different options for giving sedation? Through propofol infusion, through benzodiazepine like midazolam or diazepam. Okay. Then with
Dexmedetomidine.
dexmedetomidine, opioids like fentanyl. Okay. So there will be certain and some novel things which people are using, like ketamine infusion. Okay. So there will be certain pros and cons of everything. If the patient is hemodynamically unstable, propofol will not be a good choice. Okay. In younger population with some at risk of propofol infusion syndrome. Okay. So similarly, if you are, for example, planning for weaning, midazolam, though it's not as like diazepam, but the elimination half-life is very high in renal failure. Okay. So if you want to wean off the patient, it is better to convert it into like a combination or stop midazolam and fentanyl and go towards propofol and dexmedetomidine, because this has what the advantage that it does not cause respiratory depression. Okay. And similarly, fentanyl, remember one thing, fentanyl is highly lipid soluble. So initially, in initial phases, it is a good option, okay, because it is hemodynamically stable, it is giving blunting the stress response and everything. But if you are continuing it for a long time, fentanyl, when all the fat stores are saturated, then it becomes a big problem. Okay. So fentanyl, when you are telling fentanyl for sedation, remember this thing. And if you are giving sedation, you have to keep in mind the overall picture of the patient, whether you are going for the weaning and then the renal status, liver status. Okay. And then as I
Head
told you,
injury.
weaning. Sorry. Yes, I was about to tell you that combination, and in which conditions will definitely need muscle relaxation, muscle relaxant, especially if you have some, for example, post-op GI anastomosis. Okay. And you don't want the
Head
patient to
injury.
lose head injury. Okay. Okay. Because some people have just this confusion that they are not using muscle relaxant at all, but it is not like that. Okay. You have to use judiciously. So in these patients, you have to make a combination, because you have to achieve three things: sedation, analgesia, stress response. Okay. And muscle relaxation. So just keep these things in your mind and according to the Ramsey scale. Okay. According to the hemodynamic response. Okay. And according to the patient condition, you will be titrating it. Usually, infusion are better than bolus, and you can have target control infusion even in ICUs. Okay. And another adjunct is lidocaine. Lidocaine is recently being used for blunting of stress response. Okay, but of course, you should be taking care of liver. If there is liver failure, you will reduce it. You have to monitor signs, symptoms for last when you are telling. But there is a lot advantages in the form of stress response. Okay, which has and even reducing the requirement of even propofol or whatever you are using. Another thing which is indirectly being used is magnesium. Okay, magnesium and lidocaine, if they are asking you in detail about ICU sedation, you can tell about these things. Magnesium will have a lot of effects, but of course, you have to monitor magnesium levels and see for any signs of toxicity. Okay, so sedation, if you are using for muscle relaxants, you have to look for, again, the same pharmacological things which we have to consider in any other patient. You have to keep in consideration here as well. Okay. So what else? Yes, Ishan. Okay. So
Inotropes, vasopressors, etc.
yes, we can discuss some words about vasopressors used in ICU.
Antibiotics
That
also.
yes, vasopressors, usually the drug of choice is norepinephrine. Okay. And first choice, and then if it is failing, then you can add vasopressin or epinephrine. But first choice is norepinephrine. It is better to give through central line. Okay. And you have to monitor the peripheries. Okay. Because the skin, it can cause ischemia if it is using in high dose. When you are using norepinephrine, if you have cardiac output monitor, you can direct through SVR. Okay. You can monitor norepinephrine. And why? If for example, norepinephrine is not responding, you have to treat acidosis. And actually, it's a vicious cycle sometimes. You are giving more norepinephrine to increase the blood pressure. There is more acidosis, we have no more peripheral. So acidosis, you have to, of course, with the ABGs and also with the lactate levels. Okay. So other are vasopressin and high dose of epinephrine, adrenaline. Okay. They are directed through invasive blood pressure, cardiac output monitors, T. Okay. And overall condition in the sense, okay. So actually my aim for this session was to give you an overview, because now when we will be targeting the individual topics like sepsis, VAP, delirium, and nutrition, and yes, another thing which I have missed up till now, I will just tell, and then we will finish our discussion for a while. We will resume from here. Is the scoring system. Zishan, you like it?
Sir,
Sofa, Q Sofa, Apache.
Apache,
Okay. And then
Use mu score, new score.
SIRS score. Mu. Oh, mu is a little bit
News is
different.
not in ICU. I think it is
Actually, this
preceding the
is,
ICU.
yes, it is for example, outreach services and rapid response team. Okay. Rapid response team is for to like what I will say, that to identify the patient who is going towards decompensation, and for that it is Muse, Fuse.
The Muse news is also used in sepsis in latest guidelines of 2021.
As a concept, I'm telling you, okay. If it is written in some, because you see, I am out of practice, so you can correct me anytime, okay. Well, early warning, the basic principle of early warning scores is to identify the patient who is at risk of decompensation. And actually, there's a question we had discussed before. You can find it in ICU, the concept of different teams. So we discussed about code blue, rapid response team, critical care outreach team. We discussed about this one. What other teams were? Acute pain service team, chronic pain service team, coagulation team.
Organ donation team.
Organ donation, yes. Okay. So scoring system is to see there are some generalized scoring system like this SOFA and Apache, and there are some specific scoring system, for example, for pancreatitis. Okay. A rifle scoring system for kidneys. Okay. Similarly, for acute liver failure, there is King College criteria. And if they are going towards organ donation, so they do it with this one MELD and PELD. Okay. So this is just an overview of how you should be targeting ICU. Just a second, I will. This is a very good source, and although it is old one, but I will highly suggest you to read about it, except for some change in sepsis and some changes in, of course, cardiac resuscitation. The majority of the topics you will find very high yield. Okay, and I will suggest you to have a look at here. Okay. Okay. Yes, when we were discussing about neurological system, I forgot to mention about brainstem death. Okay. So there are certain conditions which are related to ICU and related to neurological system. One is brainstem death, one is vegetative state. Okay. And there is another terminology they ask is about locked-in syndrome. And what else? Delirium. So actually, I just in this 1 hour or so, I just try to give an idea how you should be focusing ICU. Okay. So in our following discussions, we will just try to cover number of topics. Thank you very much for your presence. We will meet again. Thank you. Bye bye.